Hello, today we're going to talk about psych mental health issues. And we're starting off with attention deficit disorder. This particular one is inattentive type, but there's basically attention deficit or attention deficit disorder, is on a spectrum. So you either have inattentive type predominant, hyperactive type predominant, or you have a mix. And most people are in a mix, and I guess that's why they decided to do it like that. So basically they have gone through the DSM-5 criteria for what it takes to make these diagnoses, and then some other differentials you might want to look at, and then some medications. So here this person has got Ritalin as a starting medication, and you'll probably find that in the literature. However, this is got for patients younger than 6. Typically we don't usually like to treat kids younger than 6, but if you did, this is one, although I would not use Ritalin. It's not one of my favorites. And with any kind of ADD medicine, it's start low, go slow. So when it comes to the stimulants, I prefer Ritalin, and Adderall is my least favorite. It has the most abuse potential. It's very cheap though. So unfortunately for people that don't have insurance, you may be stuck with using Adderall, but it's my least favorite. It has the most side effects, the most appetite deterrent, which you'll see people want that for appetite suppression that don't really need it for anything else. It has the most street value, or so I'm told. So that's my least favorite. Ritalin would be right there with it. Typically, if I'm going to start a child on a stimulant, my go-to drug of choice at the moment is Vyvanse. It seems to have a low side effect profile, and it seems to work really well for most kids. They don't have as much appetite suppressant. So, and supposedly it has little to no street value. Supposedly. Like I said, I haven't tried to buy it on the street, but I don't know. Okay, so Vyvanse is my first go-to line. My second one is probably Focalin. Typically, now this is a short acting. You have short acting and long acting of a lot of these. Adderall, you have short and long. Ritalin, you have short and long. Focalin, you have short and long. So typically what you want to do is one drug a day, one pill a day. So you want to do one long-acting pill a day. There are few, and this should be very, very few, kids that need a small, short-acting dose in the afternoon. But this should be the rarity, not the exception. For one thing, if you give it in the afternoon, they're not going to sleep at night, so then you're going to have to give them something for sleep, and then you're giving this kid, you're medicating this kid 24 hours a day, which is never a good thing in my opinion. And you also increase the risk for drug diversion. When it comes to these medications, if you have someone coming in that wants, that tells you, I can't take a 30 milligram, 310s work for me, a big red flag should go up for you. This person is diverting some of these medications, and you don't want to be party to that. So one pill a day is what we want to typically go with. Typically what I do if I start them on a stimulant is I bring them back in 2 weeks. I get Vanderbilts from the parents and the child, or if it was just the adult, and see if the medication is improving the situation. Because any kind of mental health disorder, it really has to be affect you in more than one setting. So for ADD, if your mom is the only one that's worried about, or the mom is the only one that's worried about the child having ADD, it may be that the mom has unrealistic expectations for what their child should be like, and vice versa. If the teacher is the only one that wants it, then perhaps the teacher has unrealistic expectations of what the children should be like. So you do want to get information from other sources besides just the one. All right, so I usually have them come back in 2 weeks, and then at that point they're just out of control. Then I'll go up on the medication. Another medication that you can use is Strattera. Strattera is not a stimulant. It's more like an SSRI type thing. It is 1 pill a day. You can go up. It's usually titrated up, and they have packs and that sort of thing that suggest how to increase the Strattera. If the child is stimulant naive, in other words, they haven't had stimulants before, you're probably going to get your best bang for your Strattera because it's not going to make them feel like anything. Now, I have had some kids that had some depression issues on Strattera, just to let you know, which it is a warning on this particular medication. Another medication that you'll see quite a lot, and I don't know if she has it on here, and she doesn't, is Intuniv. That's another non-stimulant medication. It's guaifenesin. You can use guaifenesin, works fine. It's usually 1, 2, 3, or 4 milligrams. You can use long-acting or short-acting of that. The short-acting is cheap, and what I do with that is I just dose it twice a day. And guaifenesin is the one that I will typically use on the children that are less than 6 that are having major issues. All right, let me think if there's anything else I wanted to tell you about this one particularly. You unfortunately are going to see a lot of ADD medicine. You're going to see a lot of abuse. I had one person come in one time that their child supposedly was taking 3 10 milligrams in the morning, 3 10 milligrams in the evening, 2 10 milligrams at lunchtime, and had a negative drug screen. So no, you do want to get them in, and they should have a stimulant in their system. We always tell people we're going to randomly drug screen you, and if you don't have a stimulant in your system, we might have an issue. And then, of course, we called the school to see if they were actually giving this kind of medicine. No, so kind of approached the family and never saw them again. So just be aware of that. I'm not going to go over all these sheets. You can read them. I suggest you do. They're really well done. I'm going to go over the major ones here. The major things you're going to see in practice is anxiety, depression, ADD. We've also got smoking in here, which I think is good. Drug addiction and gambling, you will see those, and alcoholism. So those things you're going to see. Some of the other things you just need to be aware of so that you know that they're out there, but those are not the kind of things like schizophrenia, bipolar disease. You're not going to be diagnosing those things. So anxiety is real common. I don't know about you, but I would be very happy never diagnosing anxiety and never dealing with it. But unfortunately, there's just not enough providers, psych mental health providers, to deal with all the anxiety and depression. So as a primary care provider, you're going to have to learn how to diagnose and treat. So they've got the DSM-5 criteria here, and you notice for anxiety, it's really got to be going on at least 6 months. So this is not like I felt anxious, I'm going, I want to go on medication. All right. And then they've got some different labs you might want to think about, and of course, one of the big things you want to think about are, things like hyper or hypothyroidism, depending on which way you're going. Of course, for anxiety, you would think about hyper, but that's something you definitely want to rule out. So one of the things you're going to look at for this is the SSRIs, okay, to treat anxiety with. I was just talking to someone the other day, and they were treated with episodic anxiety for like speaking events with just some low dose digitalis, and I thought, well, that's an interesting idea. And they said it really worked well for them, but they knew that they had an anxiety while for public speaking, and that's what they used, and it worked really well for them. But if it's an ongoing, like a chronic type thing, an SSRI is probably going to be your best bet. Now, benzos, they've got here second-line treatment because of risk of dependency. Absolutely. I am not a fan of a benzo, especially for a younger person. I worked for a while in the ER, and what we did, what the nurse practitioners did at that point there is worked in the drug addiction, like the folks came in for psych mental health and drug addiction, and the benzos were huge. So I would not give this as a treatment for anxiety. I had a child come in from the ER, and they had been given some, can't remember which one now, one of the benzos anyways for anxiety in the ER, and came back and they wanted a prescription, and I was like, absolutely not, like a 16-year-old. So this is where therapy, biofeedback, that sort of thing would be helpful. Sometimes just knowing it is anxiety and nothing else is helpful. So just kind of be aware of that. And once again, just because what I'm told on boards is thyroid, thyroid, thyroid. So you better know your thyroid. So just a nice, once again, review of hypothyroidism. Remember, 10% of women over 35 have hypothyroidism, so it's very, very common. Less common in men, but it's definitely still there. Okay, this is Munchausen by proxy, and then you have Munchausen. So Munchausen is when it's you. Munchausen by proxy is when it's like a child, usually. I guess it could be an elderly person or something. You're imposing this on somebody else that's kind of somewhat dependent on you. I've seen a couple of cases where, like I said, that I felt very confident the mother had Munchausen by proxy. One child they got without any sort of diagnosis. The mother talked somebody into in Charleston and putting a G-tube in her child. I've seen it various times. Usually by the time you catch on to them and you're kind of questioning, then they're moving on to a different provider. We had depression a couple of different ways in this particular talk. One was major depressive disorder, and one was situational depression. And I really want you to know the difference between the two. Situational depression is short-term stress related. Your dog died. You can point to the event that makes you depressed. Okay, your husband died. That would make me depressed, but it's not the same as a major depressive disorder, okay? So you have a reason for depression. These people need time. They need maybe therapy. They need help through perhaps the grieving process. They usually don't need medication, all right? So you want to go through your DSM-5 criteria for depression and figure this out, okay? So the difference is, let's think about what an SSRI does. It's a serotonin uptake inhibitor, right? So if you have the proper amount of serotonin circulating and your body uptakes it correctly, your brain is functioning normally, you don't have major depression, all right? Now, apparently, I've never taken an SSRI either, but apparently if you take an SSRI, you do feel better, even if you don't have depression. That's what I've been told anyways. So, just to take that and say, do you feel better, is not good. So that's why we need these criteria for how to make the diagnosis, all right? So this kind of workup is almost a better workup for someone that has a more ongoing kind of depression rather than just a situational depression. Okay, so I know that she wanted to show that she was thinking about all this, and I'm very glad, because these different kinds of things can cause depression. So those are definitely physical reasons for depression, and we definitely need to know that. And there are different scales that you can use for depression. Now, when it comes to depression screening, this was really interesting because I wanted to know what the guidelines were for depression screening. And the guidelines are all over the place, basically saying every adult should be screened for depression. But then there are certain groups that really need to be screened for depression. Teenagers, one, because we know that suicide is one of the leading causes of deaths in teenagers. The elderly, because they're at very high risk for depression. People with chronic illness, like bad chronic illness, are very high risk for depression. Pregnant and postpartum women are at high risk for depression. So there's certain groups that we absolutely need to be checking and screening for. And then there's other groups that, everyone else that doesn't fit any of those should be screened every once in a while. But there was no definitive statement as to how often these people should be screened or not. I don't think anybody kind of really knows. So just getting a real simple screen for depression and kind of making it part of your routine care probably wouldn't be a bad idea. But anyways, they've got some SSRIs, and this has got first-line SSRIs. In the other article that actually, I'm not going to pull it out, but the other person that did major depression, I have an article linked in there that was talking about the two. It was a study that they looked at the two best. Now, typically you think about Prozac and Zoloft and Celexa as being like first-line drugs. But they had the two best. One of them was Zoloft, and the other one, I can't think of what the name of it was right now. But it was a surprising one. Anyhow, if you want to take a look at that article, I don't think you'll see that on any kind of boards because that's not necessarily mainline thinking. But I use Zoloft a lot. If you look at the indications for Zoloft, it's for depression, PTSD, anxiety. It's got lots of indications, so that's why I started using Zoloft. And then you get comfortable with what you're using, you know how to dose it, and you kind of know how it acts. So I use Zoloft if I don't have any reason to use something else. Now what I will do is ask the parent or the person, is anybody else in your family have depression, anxiety, whatever else I'm using an SSRI for? If they tell me, yeah, my sister does, my mother does, I'll ask what are they using, is it working for them? And because their chemistry is similar, I'm going to try that one first. And I often find that saves me a lot of time in trying to figure out which one is the best. But if there's no preference, I typically use Zoloft and have good results with it. Now, the other thing that you need to keep in mind is a lot of these medications, and there's varying degrees of weight gain that you expect to see with these, but that can make you depressed. So if I have an overweight person, especially right now I'm treating a girl who's morbidly obese. She's 18 years old, and she definitely has depression. And I put her on Wellbutrin, and she has started losing weight, probably from part of it getting out of the depression to the Wellbutrin kind of helps. Plus, I'm treating her type 2 diabetes, and we're treating her really low vitamin D levels. So all that's kind of helping her with her weight loss. But she's lost like 40 pounds, which is great over the last 8 months. So it's not a quick fix. So anyhow, got a good thing here, and this is why I wanted to bring this one up, is a good thing here on some drugs. But you may want to just look at differentials, like what are the indications for different SSRIs? What are some of the more major side effects for some of them? Prozac and Paxil have been around forever. I don't tend to use them a lot because of the side effects, but a lot of people do, and they work well. So you'll develop your own group that you use, but kind of look and make an intelligent choice as to why you use one versus another. For instance, I use the Zoloft because of the indication profile. Okay, I'm just going to go over smoking, and then the rest of them, like I said, I would like for you to go over yourself. Smoking, good gracious, don't we all need to be able to treat smoking? So they've got some medications down here. I think that I don't know which is harder to overcome, smoking or obesity. They're both extremely addictive, but at least you can do without smoking. You can't do without food. So just kind of look over the rest of these, and I hope this little short overview is helpful to you. Thank you.